Okay, so cochlear implants. So cochlear implants are different from hearing aids. They are used on people that are, severe to profound bilateral deafness. So a person who would be a candidate for a cochlear implant would have an intact auditory nerve, but a cochlea in which the outer hair cells were damaged and destroyed and unable to process sound. So cochlear implant skips the outer hair cells and it electrically stimulates the auditory nerve. So like I said, you need to have severe to profound bilateral, so both sides, sensorineural hearing loss. There's always going to be a trial period with hearing aids, realistic expectations, and a committed family. Cochlear implants are not a quick fix. They take a lot of speech and language therapy. They take a lot of work. They take a lot of practice. They take a lot of effort. They take a lot of time. There are deaf schools filled with kids that have cochlear implants that were not successful with them. Okay, so they're not a quick fix, though they are absolutely amazing in what they can do. So you have to ask some questions. Is implantation consistent with the patient's medical or health status? Is it feasible? If the child or the adult does not have an auditory nerve, then you cannot do a cochlear implant. Cochlear implant only helps people with damaged cochlea. So there has to be an auditory nerve for the cochlear implant to electrically stimulate. Will the implant yield greater communication benefit than traditional hearing aids? If the child or the adult is doing fine with hearing aids, then there's no need for a cochlear implant. What's the patient's physiological status, their family dynamics, their educational and rehabilitation setting? So, like I said, if the family doesn't have time to commit, if they don't understand like the responsibility in getting the child to their speech and language therapy and to working all day with the child. There's a video that we watch in oral rehab with a family that has cochlear implant, and the mom says at the end of the day, she is just so tired from talking because she has to spend her whole day talking and stimulating the child with speech and language so that the child can learn how to use the implant. So here we are. We have external processes and we have internal processes. So over here, that's the microphone. It picks up the sounds. It gets coded in the speech processor. Electrically, it gets sent through the transmitter, through a radio wave to the receiver stimulator, down through the middle ear. The middle ear has nothing to do with it anymore. There's an electrode array inserted into the cochlea. The electrode array electronically stimulates the auditory nerve. So it is implanted, the internal receiver in the skin behind the pinna. There's a wired electrode and a tiny coil. There are 22 active electrodes, each covering a specific range of frequencies. So there are 22 active electrodes. We have 12,000 outer hair cells. We have outer hair cells for every frequency of sound we hear, from 20 hertz to 20,000 hertz. With the cochlear implant, there are 22 active electrodes, and those 22 electrodes cover the range of frequencies that we hear. So a cochlear implant is much grosser in its processing than our outer hair cells. Our outer hair cells have much finer processing. So it is amazing how well this works. But cochlear implant sounds are different from our sounds that we hear through our normal healthy cochleas. It is a different type of sound because it is not as fine as what we currently have. There's a small microphone that sits on top of the pinna. It feeds the electrical impulses through a speech processor behind the ear. The speech processor is coded. It is delivered to a transmitter, which converts it to magnetic impulses, not radio, magnetic impulses, transmitted across the scalp into the electrode array. The electrical signal is sent up through to the cochlea. The cochlea, there it fires. It says, forget the outer hair cells. We'll just fire to the auditory nerve ourselves. So the reason you have to have severe profound bilateral hearing loss is because let's say you did have like a mild to moderate hearing loss. Inserting that electrode array in the cochlea will destroy whatever outer hair cells there were. So you have to have profound bilateral sensorineural hearing loss for this to be a viable option. And there you see the electrode array, 22 to 24 electric, little beads that directly stimulate the auditory nerve. So sounds are picked up, they're processed, they're sent through the skin to the transmitter, down the coil, down the electrode array, electrically stimulate the auditory nerve. And you see it gets coiled up the cochlea. It doesn't go all the way up the cochlea. The cochlea is the size of a dime. It's super tiny. It's super delicate. So it's not quite, they can't insert it all the way up because they would end up puncturing the cochlea. And if you puncture the cochlea, then you're in big trouble. So after the internal parts have healed, about 4 weeks later, the external components, the speech processor, are fitted, and the audiologist programs or maps each of those beads in the electrode array. The surgery is like a one-day surgery. Maybe it's 2 to 4 hours. The patient doesn't even have to stay overnight. It's not incredibly invasive, but it takes a few weeks to heal. Then you go to the audiologist, and I'm sure you've seen all those things on YouTube where all of a sudden the baby looks up when it gets stimulated for the first time and it wonders, what's that? So the audiologist will work with each of those beads, and they will program the beads for timing, temporal cues, frequency. So each bead covers a range of frequencies and intensity. Cochlear implants do not amplify sounds. They give the sounds the same level we hear at, so they have to be programmed for soft sounds, medium sounds, and loud sounds. Now, cochlear implants can also be used in adults, but they can be used in adults that are post-lingually deafened. If a person was deaf since infancy and is now 30 years old seeking an implant, they are not going to be a candidate because the brain has already set. The brain has taken over that area of the auditory cortex. Do you understand what I'm saying? So cochlear implants are much more successful on infants and young children because their brains are still very plastic. Their brains can still be molded. As an infant or child ages, your brains get set. You get set in your ways. So a cochlear implant is not a viable option for an adult that has never had hearing because they don't have those brain pathways to be successful with a cochlear implant. However, if an adult had hearing their whole life and lost it, because of some idiopathic disease or some virus and they lost their hearing overnight, they would be a good candidate for a cochlear implant because they have the brain settings for it. So adults who get cochlear implants, they have to be free of any other physical or physiological problems, and they have to have realistic expectations. For children, going back to that profound bilateral hearing loss, 18 to 24 months, now they're getting implanted around a year. The earlier a child is implanted, the better they'll do. So the less time the child spends without hearing or without being auditorily stimulated, the more successful they're going to be with the implant. They have to have an active and dedicated family because the family is really the one that's going to be doing most of the work. You could see a speech pathologist 3 hours a week. You see your family, I don't know how many hours are in a week, way more than 3. So the family needs to be fully committed to the time and the effort that are required for this. There's going to be a team on board for the child. The otologic surgeon, the ear surgeon, the pediatrician, a psychologist to help the family, a psychologist to help the child, an audiologist, and then the speech-language pathologist. So the audiologist determines if the child is a candidate for an implant. The audiologist is the one that is responsible for programming or mapping the cochlear implant, and along with the speech-language pathologist, the audiologist is the liaison for the child's educational setting and ensures that the teachers and those around the child are familiar with the device and how to work and how to keep it working, and then they'll provide extra support for educational, good acoustic environments, preferential seating. FM systems can click right onto those cochlear implants. Remember, cochlear implants are not a quick fix. They require intensive therapy, extensive speech perception training, lots of speech and language therapy, active involvement of the parents step by step. So children deafened before the age of 3 who receive the implant will maximize their chances of interacting with the hearing world. Before 2.5, there are significantly stronger outcomes in consonant production and accuracy and vocabulary compared to age-matched peers who receive the implant later. So the earlier the child is implanted, the better the child is going to do with spoken language. With appropriate habilitation, there's improved personal and social adjustment for young children, but there are still ethical considerations. And when the cochlear implants first came out, people in the deaf community were not supportive of them at all. They thought it was a threat to their community. People in the deaf community are very proud of their deafness. They're very happy to exist in their world without hearing. And they put forward the idea that it's not ethical for parents to make the decision for this child who are too young to choose whether they want to live in the hearing world or be in the deaf community. We could talk more about that in oral rehab. All right, so children that do receive cochlear implants, though, they do outperform children who have hearing aids, and they do outperform children that receive no support. Children that have cochlear implants are able to monitor their own voices, their vocal pitch, their loudness, so they don't have that deaf speech. It's more common now that children are getting bilaterally implanted, so binaural implantation is now much more prevalent than it was 10 or 15 years ago. So the reason people would only get one cochlear implant was that idea, like, what if it doesn't work? Can we save the other ear? But the thing is, unless the other ear also gets stimulated, that part of the auditory cortex is going to be taken over by other areas of the brain. So there's no sense saving one side. So now we're doing binaural implantation, and they are very promising. Children are doing well with their binaural implantations. The success with the cochlear implant. For adults, they have to be postlingually deafened, and the key to success for an adult is a shorter period of time deafness. So an adult that's been deaf for 3 years versus an adult that's been deaf for 10 years will do better. The less time an adult spends without hearing, the more successful they're going to be with cochlear implant. With children, like I said, it's age of implantation. So the younger the child gets the implant, the better off they are. They also need to have a collaborative group behind them and a supportive group behind them that can help move them forward, maintain the device, provide speech and language therapy, and then have appropriate expectations. So there's going to be ongoing monitoring. The child will come in for mapping every few months initially, and then as they get more comfortable, more experienced with it, maybe, twice a year. And we can talk again more about it in oral rehab.